Good evening. Welcome to the May session of the Virtual Tumor Board. Very excited today in the news of the Orator 2 and our recent meeting. We have a very timely session on TORS versus radiotherapy versus probably de-escalation. We are very fortunate to have our expert panel tonight, Dr. Caitlin Stepan from Northwestern University, Dr. Peter Ziglewski from University of Florida, and Dr. Michael Sim from Indiana University. Our discussants are Dr. Jeremy Richmond from Mass Eye and Ear in Boston and Dr. Amy Hessel from MD Anderson Cancer Center. I also see that quite a few of other friends have joined. Thank you for joining us. Hopefully we can ask you guys to also participate. To start the session, Dr. Caitlin Stepan gonna present the first case. Caitlin, go ahead.
Great, thank you. Let me share my screen here.
Swap the display again.
Swap display. Okay.
Okay.
Looking good?
Yeah.
Okay, great. So for our first case here, we have a 62-year-old male, non-smoker, non-drinker that presents to clinic with a right-sided neck mass. On exam, he's found to have a right tonsil mass without significant base of tongue or palate involvement, as well as a right level 2, roughly 3 centimeter enlarged, fairly mobile lymph node. Biopsy is performed in clinic and shows HPV positive squamous cell carcinoma.
Okay, let's just stop 1 second before you go in. Jeremy, let me ask you this. So this is a common scenario. What's your routine when you see these patients? What's your imaging routine for these folks?
So we tend to get a CT scan of the neck and chest.
Do you get an MRI routinely?
No, almost never, unless it's base of tongue and I'm concerned about deep extension.
What about PET scan? Does everybody get a PET scan?
No. So I did previously. So Hopkins, we did PETs on everyone, and we just have a different institutional protocol. We get CT neck and chest on everyone.
Okay, very good. Let me ask one more person. Peter, what do you guys do in Florida for these cases?
Same thing, CT neck and chest. We find some of our insurance doesn't cover a PET scan unless you get a CT first. Mm-hmm. And our neuroradiologists are fantastic and they prefer us to just do a CT. So we start with that.
What about an unknown primary?
What about what?
An unknown primary.
Well, that's a different story.
Yes.
Yeah, Ryan. So what about, let's see. Let's just stick with the tonsil for now and then we can move forward. Okay. So obvious tumor, most people would just do a neck and chest. What did you decide, Caitlin?
Great. So we got a CT neck and chest. I have limited imaging here for you guys, but patient had a 2 centimeter right tonsil mass, 1 pathologic right level 2-3 lymph node, and his chest imaging was normal.
Okay.
Next, I have a brief clip of his sorry, let me go back to this imaging here. So also on the imaging, we found a fairly tortuous right internal carotid, very near the tonsillar bed on the right, with a retropharyngeal course. And so on his clinic scope exam, you can see brief clip here, but the right retropharyngeal area is full and you can see carotid pulsations there.
Yeah. Okay. So you have, okay, yeah, that's a great video. Okay, so this can happen to anybody. Jeremy, what to do now?
Well, so I mean, the physical exam is the most important part of all of this to determine candidacy for TORS. So getting your finger back there and making sure that the tumor is mobile and getting an assessment of where it is on the posterior pharyngeal wall, especially given the concerns of the carotid. So that would be my next step. I don't know necessarily if you need to do that in the OR as a separate DL, but usually in the clinic, you can get a good assessment of that.
How often do you do a DL in the OR, like diagnostic DL, to help you decide if you're going to do TORS or not? So you give us some like ballpark, kind of.
So yeah, my situation isn't generalizable because we have our own robot that's just for head and neck. So the answer is never. We do all of our TORs, DLs, and everything together. If it ends up not working out, then no one else is using the robot. So
okay. All right. So I see also Dr. Gross has joined us. Welcome, Neil, and I see Dr. Duori. So if it's okay with you guys, I'm also going to ask you a couple of questions here and there. All right. So what did you decide in this case? Neil, are you able to make a comment? What would you do for this case?
No, I agree with Jeremy. I mean, I think in general, when you're starting your practice, I would err on the side of frequently staging an endoscopy just to map out the tumor and more for exposure to make sure you can access the tumor. But it's reasonable once you get comfortable assessing patients in the clinic, then you can supplant that with sort of same day procedure.
Okay.
So one thing I wanted to highlight here, and that will kind of inform the rest of our discussion, is the retropharyngeal carotid on the side of the tumor. And just to kind of pull everyone's practice in terms of, a patient with a tonsil cancer with a retropharyngeal carotid that could be exposed during the dissection. A, is this, a surgical candidate in your book? And B, I guess, TORS versus open, would you consider doing the primary or neck first? So just in terms of management from a surgical standpoint, the nuances of that as well.
Perfect question. So let's pull our experts. We'll ask Dr. Richmond first.
So for me, TORS is still on the table. I think there's some caveats to that. And, I think Neil points out that this is not your average TORS case and that you should, enter such a case with some trepidation. This is not the first TORS case or the 80th TORS case that you want to do. So I'll leave it at that and just say that it's a relative contraindication, but I would still strongly consider TORS for this patient.
Okay, great. Dr. Gross.
Yeah, I mean, I think it's a relative contraindication. So, beware of an aberrant carotid artery. Obviously, that's a deal breaker if you get into it. So it just takes more careful assessment of the exact location of the tumor relative to the anomalous vessel.
Okay, I see Dr. Duori from Pittsburgh also joined. Uma, what would you guys do for these cases in Pittsburgh?
So this is an interesting dilemma, right? So I think you've heard everybody say this is a relative contraindication. I think you should be careful of how we define relative in these sort of cases. And I'm going to get a little philosophical here, so bear with me. But these are the kind of cases that can lead to devastating complications, which then is reported in trials named Orator as being the death knell of robotic surgery. So I think that, factually speaking, this is a relative contraindication. I think this case could be handled with robotics. I think you could take the tumor out. You have to be very careful in the technique of dissection to ensure that this retropharyngeal carotid is not damaged or exposed. But if it is, then the complication that ensues from this could be potentially life-threatening and devastating. So I guess I'm echoing what others are saying, but you have to couch this in the context of your organization and your practice pattern and the amount of risk that you're willing to accept when a case doesn't go well. And if your institution is one that is heavily non-surgically oriented and you are now attempting to sort of broach the introduction of TORS into this area, then I think that this is not a case that should be tackled in that scenario. If, however, you're like in an institution where surgical management of these diseases is considered to be the primary modality, then I think it's very reasonable to have a go at it, recognizing that there is potentially a need for a flap or reconstruction to avoid this major complication.
Sounds good.
I think, can I just add,
yeah.
this is one of the really important points that comes up in the whole order discussion, right? That Uma was referring to. So with order and order 2, they randomize patients basically based on stage, right? So T1, T2 tumors, but there wasn't necessarily careful patient selection. That's our job, is to identify the patients that we think are the safe for the surgery and are going to benefit functionally. So, you know, it's all about patient selection, and certainly early on, you would avoid anybody with the retropharyngeal carotid, I would say.
Excellent.
And if I could just make a quick point to that as well, to what Neil was saying. The other thing you need to consider is the experience of the surgeons involved as well. Some of the surgeons in the order trial were straight out of fellowship. And so I think there's a good argument to say those might not be the best surgeons to be tackling cases like this or even difficult ones. And so that's another factor to consider when you look at the data of a study like that.
Okay, great. So we have 8 minutes to finish this case. A very non-controversial, easy case. Okay, Caitlin, let us know what you decide.
Well, so
You have more questions?
quick question. Yeah, if you are deciding to take this on surgically, which I would say in many cases, most of us might pursue this surgically in the case of salvage, you know, if we really have to, versus kind of primary treatment. So if you do decide to approach this surgically and you feel that they're a TORS candidate, do you routinely do the neck first and try to lateralize the carotid, or does, you know, do the experts have any other tips or tricks to make this as safe as possible?
Okay, let's get 3 quick opinions from Jeremy, Neil, and Uma.
So I agree. In the salvage undertaking, I would do the neck first to lateralize and protect the carotid. In the primary undertaking, no, I do the TORS still first.
You do TORS first, okay? Dr. Gross.
Yeah, same for me. In the salvage setting, I routinely do the neck first, but not in the primary setting.
Okay, Dr. DeWury.
I do the neck first. It doesn't matter if it's salvage or primary, depends on how worried I am about the vascular compromise or potential vascular compromise. I think you've seen here the nice dissection with the cotton patty. Mike Hinney's described this very nicely. I think it works. It's a good trick and it works well.
Okay, very good. All right, so we got 2 opinion one way and 1 opinion. Perfect. All right, Caitlin, what did you decide?
Great. Lastly, you have exposed carotid, this exposed retropharyngeal carotid after your resection. How, A, do you have to reconstruct this? And B, how do you decide to reconstruct this?
Okay, same folks. Dr. Richmond.
Yeah, so I guess I wouldn't anticipate having the carotid hanging in the breeze back there. So I'd leave some fascia and hopefully fat over it with the primary dissection. If the carotid were really completely bare, then I need to cover it with something. So either a local muscle flap or a free flap.
Got it. Very good. Dr. Gross.
Yeah, so in patients who've been previously radiated, I'll have a very, very low threshold for putting in a flap, kind of regardless of the vessels. They just don't heal well. So certainly in somebody where there's concern about the carotid, definitely you would need a flap.
Got it. Uma.
Yeah, same. So just to expand on that a little bit, you know, Neil and I participated in a study from the Royal Marsden. Vin Pelleri is the lead author. It's currently in press at JNCI on salvage surgery for TORS. And you need a flap, basically, is the conclusion of that. These people don't heal well and they have really bad outcomes if you don't do a flap. If it's a primary case, which I believe this one was, there are many, many options for this. A free flap is one. Local flap can be either a FAM flap, which can be rotated to cover it. Megan Turner has described the nasoseptal flap, which can be brought down through the nose and used to cover it. But bottom line, you got to cover that carotid, whichever way you can get for it to be done.
Okay, very good. Caitlin, what did you decide? And also in the chat box, Dr. Wheaton made some very good comments if you guys read it. Okay, go ahead.
Great. So in this case, you know, as a primary case, he would be an excellent non-surgical candidate. So this is someone I would send, you know, likely for non-surgical therapy. Brought in some pictures and other discussion points in the salvage case, you know, salvage cases or other scenarios just for sake of discussion. But that's what would happen for this case in particular.
Perfect. So you decided on non-surgical treatment.
Yeah.
Okay, I think that's very reasonable. Any last comments about this case, Jeremy?
Can I just mention, because I think one thing that does potentially impact on one's enthusiasm to do this is really one's philosophy on margins, on managing margins for TORS, so, I think there's two general thoughts on how we go about doing margins, and there's that which was originally really espoused by Penn, of doing this in-block resection, going full thickness through constrictors, and doing kind of the same TORS operation regardless of your T. So T1, T2, doing the entire lateral oropharynx or base of tongue, versus more of a TLMS approach, which is taking negative margin or very narrow margins that are biopsy proven negative. So I'm a member of that latter group. I take narrow margins, and so because of that, I'm more comfortable doing procedures like this where that could potentially get close to the carotid, because I always try and leave tissue over the vessels. Whereas I know others are really dogmatic about doing full thickness constrictor, getting down to fascia and so on. So I'd be interested in knowing from the fellows, like how most people are training now, if they're doing, strict in-block resections with TORS or a little more tumor centric.
Okay. So if you have any comments, please put it in the chat box. I see Dr. Hessel joined us. Welcome, Amy. You were hiding in the back. Dr. Hessel, what would you recommend in this? Did you see the beginning of the case? I think you're muted. Okay. Amy, hello. So anyone have any comments regarding Dr. Richmond's question? Please put it in there. Any last other comments from Dr. Hessel, Dr. Gross, Peter, anybody, Mike, about this case?
I just want to make one sort of comment
Sure.
Based on what Jeremy said, which is that I think it's a very good point, this idea of on block, not on block, etc. No matter what you do, I think if you're going to tackle any of these TORS cases, it's so important as a young surgeon to get into the lab and really understand the anatomy. Try to get some time on a cadaver if you can, and understand where these fascial planes transect, where these fascial planes transition from one to the other. I saw a comment also from Ryan that the carotid usually is hidden behind the fascia, right? And that's true, but if you're talking about retropharyngeal carotid, yes, it's hidden behind the fascia prevertebral. But if it's lateralized in sort of its anatomical position, it's still lateral to the constrictor plane and the styloid fascia, the styloglossal stylopharyngeus. So just get to know your anatomy really well. So you're not just sort of hacking through muscle in that area, that you understand what you're taking and what you're leaving, because that will keep you out of trouble.
Very
Yes.
good.
Yes. Sorry, let me just clarify. We're all doing en-block resections. I didn't mean that we're doing a piecemeal resection with TORS, but just there's a narrow margin way where you're going, closer to the tumor and taking out smaller tissue for smaller lesions versus, going all the way through the constrictor.
Yeah. And if you look at Michael Hinney and others, a lot of them with the laser, when you have even bigger magnification, a lot of them actually, they don't take the entire constrictor. They just go beyond the tumor.
Right.
And they are moving in the constrictor, which is a little bit more difficult with TORS, but it's possible that you actually leave
That's what I'm referring to. Yeah.
Exactly. Just leave a little bit of a constrictor in the patient. And when you take the specimen out, and I used to do this, you do see the muscle on the specimen, but there is also a little bit of a muscle left in the patient. A little bit of finesse, but anyway. Okay, great case. Yeah, please.
Hey, just one quick comment. Leaving aside the technical aspect of the safety of the resection, which is a big thing to leave aside, but if you just look at the function and what you're anticipating with regard to best oncologic treatment, if you think surgery will allow single modality treatment and the only thing in your way is a retropharyngeal carotid, a small forearm or your best reconstructive option for this patient will still be better function long-term than radiation in, you know, a 45-year-old who just happens to have a retropharyngeal carotid. So I would just throw that out there. Again, you can't leave aside the experience of the surgeon doing the resection, but just from a reconstructive perspective, if you can avoid radiation, even with a flap, their function will be great long-term.
You know, I think we all agree, but I guess our orator colleagues are now believing that radiation is end all be all. So we got our work cut out for us. Thank you so much, Caitlin. This was fantastic. Let's move on.
Thank you.
Dr. Zyglovsky is going to have the next case. Peter, if you please share a slide, and Dr. Ryan Jackson is going to help us with the moderation as well.
Go ahead, Peter.
Sorry about that. Let me get my screen going here again. All right, can you guys hear me and see me?
Yeah.
Okay, perfect. All right, well, thank you very much. All right, so we'll just jump right into this. So this is a patient who came into my clinic, a 57-year-old gentleman with a 1-month history of a neck mass that he noticed while shaving. Pretty typical presentation. He's had an upper respiratory tract infection right before this, and he thought it was related to that, and it just wasn't going away. He had no other symptoms at all. He's otherwise healthy, on no medications. He works full-time, very active guy, non-smoker, but typical for the rural areas of Florida. He chews a lot of tobacco, about 5 to 6 times a day since he was a youngster. And he went to go see his PCP, and they obtained an ultrasound. So he came in with this, and it said he's got an abnormal jugular-gastric node, 2.6 centimeters. That's about all the information they gave us. And then his exam was really unremarkable. I don't have any interesting pictures or videos to show you. Basically, just a small palpable neck node of level 2 on the left. And in his oropharynx, his tonsils looked symmetric. They were non-tender. Actually got a really good exam intraoperatively, didn't have much of a gag reflex. Base of tongue was soft, non-tender as well. So we're sort of in a situation where we're suspecting, you know, maybe this is a cancer. So we did an FNA in clinic and showed P16 positive squame. And so then following that, we got our imaging. As I mentioned earlier, we would do, we'd start with the CT neck and chest. And if that didn't help us, we'd move on to a PET scan. So first CT neck shows the node right there, level 2. Looks pathologic, it's round. And the oropharynx just looks crowded, doesn't really show anything exciting in the tonsils or the base of the tongue. So, you know, at this point, we're thinking potentially a carcinoma of unknown primary. So we were able to get him a PET scan. And this is a good representation of his PET, this cross section right here. And our radiologist gave us some values here for the SUVs. And so what we have here on the right side and the left, pretty comparable SUV, not that much above biologic values. And then lymph nodes on the right side, about 3.5 SUV. And then on the left is the hotter node, that's 6.3.
Okay.
So we don't have a definitive source of the cancer yet.
So let's just stop one second here, and let's ask the expert. How would you guys approach unknown primaries nowadays? Let's ask Dr. Richmond, then we'll ask Dr. Hessel.
So this patient has bilateral palatine tonsils. So you can do, I think, one of 2 ways. I don't know if there's necessarily a winner. You can schedule a separate DL with tonsillectomy. We usually, if we do that, we usually take out both palatine tonsils if there's no target. And then if that's negative, then do a TORS lingual tonsillectomy and neck dissection. Personally, I do it in one surgery. I usually take out the ipsilateral palatine tonsil and the lingual tonsils if there's no target with the neck dissection. But I do not do both palatine tonsils and both lingual tonsils because you'll end up with oropharyngeal stenosis in a very unhappy patient.
Dr. Hessel, how do you approach unknown primaries nowadays? I think Dr. Hessel is still muted. Okay.
I can tell you, Bobak, that at Anderson, we've recently implemented an algorithm for unknown
Please.
primary because they're used before that, there was not really consistency. And it fits in with the ASCO guidelines that were published, I think about 18 months ago. And essentially follows what Dr. Richmond was describing. So patients who are PET negative, who are true unknown primaries, PET negative, exam negative, would go to the OR. If they have palatine tonsils, that would be resected, sent for frozen. If that's positive, then you ensure a negative resection. If that's negative, then do the ipsilateral lingual tonsil. So it's really an ipsilateral procedure, but again, the only patients who would be included in that are patients who have unilateral disease. So patients who have unknown primary disease, but it's bilateral, would not go through that.
And then, Neil, quick question for you. This is for HPV positive. I assume that you guys routinely do P16 on the neck node and the FNA. Is this for
Correct.
HPV positive or both HPV positive and negative?
HPV positive.
HPV positive. Okay, just want to make sure that I got that. Uma, what do you guys do in Pittsburgh? You guys are like the publishers of unknown primary.
Yeah, I guess we have a lot of people that we can't find stuff. Yeah, no, I agree with what my colleagues have said. The ASCO guidelines were written with lots of sort of thought about this. I think those are all very reasonable algorithms to go down. And so the bottom line is we use image and then attempt to do as little surgery as possible. That's sort of the spirit of the guidelines.
Okay, very good. Ryan, what do you guys do at your institution, Dr. Jackson?
We tend to know who we're going to recommend surgery for going in. And most of our unknown primary patients have solitary small volume lymph nodes, and our institutional practice is to operate on those patients up front and spare them additional therapy. So we go in with the mindset that they're getting surgery. The exception is those patients with really bad nodal disease with gross extracapsular extension. So we treat those kind of separately, but the typical unknown primary patient, we go in and try to identify it, like Jeremy said, with the ipsilateral, lingual, and or palatine tonsillectomy. We don't do both up front. We do one at a time and send them for frozen. We find them about 90% of the time, and we get negative margins at the time of surgery, and we do a concurrent neck dissection on that patient.
Okay, great.
For the bad neck disease patient, we would just try to find the primary and not necessarily get negative margins because we're not managing that patient surgically. But we would do the search fairly similarly with more of a mucosectomy.
Awesome. All right, Peter, let us know what you decide.
All right, great. So I guess we talked about the options, and another option that some people would consider, some of our radiation oncologists would even push for, is just to go straight to radiation and not even worry about the primary. But I think we talked about these options here, using a diagnosis approach, tonsillectomy, base tongue mucosectomy, and then discussing options with the patient, or a therapeutic approach, which I certainly prefer doing in most cases, as Jeremy was discussing. Do a frozen section at a time and the wide local excision, and then do a neck dissection at the same time. So my discussion with this patient was all these options, and he opted to go with a diagnostic approach. So
to stop right there real quick, Peter, I want to ask maybe Jeremy and Uma to see which one or who does a diagnostic dissection versus actually sends them for frozen at the time of surgery, because I've heard two philosophies where people just try to get a diagnostic mucosectomy, wake the patient up and send them home, and then plan their definitive treatment with a multidisciplinary team, versus those that have already had their multidisciplinary team plan to go straight forward with surgery and get negative margins on frozens. Jeremy, what do you guys do?
So, I mean, the surgical procedure for the unknown is relatively the same, is the same for me, whether, going in, it's essentially mucosectomy, right? I go down to the muscle layer and take off the tissue. I put it on the back table. I take it to pathology. And if there's an obvious target in it, if I feel a nodule, then we'll do a frozen on that. And then I can go back immediately to resect the area that correlates with that. But the reality is that, usually it's nothing. It's just a blanket of nodular tonsillar tissue, and that's it. And then if I get a positive margin there, on the permanent, I don't go back. We consider that a biopsy. It's not a positive margin, and most patients will just get radiation. The neck's been done at this point. But does that make sense? Is that clear? Like, it's important to clarify that this is really just an extended biopsy rather than an attempted oncologic resection. So when your med onc is seeing that there's a positive margin, if there's a focal positivity deep, that they don't throw in chemo on top of it.
Does anybody here wait for frozens routinely to assure negative margins on their tonsillectomy or lingual tonsillectomy?
I do. This is Neil from MD Anderson. You know, I think a lot of it does depend on your support from pathology. So, you know, we're lucky enough to have dedicated head and neck pathologists available all the time. So, you know, I'll send the tonsil and they'll breadloaf it and they'll look for the primary. And if they see it, they'll tell me the margin and I'll know on the spot. You know, that's not the case in most places. And so I think it is important to come up with a strategy that works for your institution and with your pathologist, because you don't want to be in a situation where you're burned and having a lot of positive margins, where you're doing a lot of dissection and then positive margins that basically then your procedure doesn't count for anything more than a biopsy.
I agree.
Neil, will they do that on the entire? I mean, the base of tongue specimen can be very large.
The basic tongue specimen is usually the same size as the tonsil specimen. You know, I mean, I don't do the whole base of tongue. I do ipsilateral. So, yeah, they'll do it.
Yeah,
So I think what everybody's getting at here is a question, which is the heart of this, which is what is the sensitivity and specificity of frozen section analysis, right? I mean, that's really what we're sort of asking in many different ways. And so without spilling the beans, you know, we have a paper coming out on this because we studied this prospectively, and hopefully we'll get it, you know, all the data analyzed. But I think that's what everybody needs to do within their institution and figure out what is the value of your pathologist in looking at this, because spending 20, 30, or even whatever, 15 minutes waiting for frozens if it's going to not tell you anything as a deferred or we can't find it is a waste of anesthesia for the patient, in my opinion. So I think that
I think that's important. Exactly what you said. At our institution, we do exactly what Neil does. We start the neck dissection and complete the neck dissection while they're looking at it, so there's no wasted anesthesia time. But you do have to have pathology that's willing to breadloaf a specimen and look at 20 slides on one tonsil, kind of like a sentinel node biopsy.
Right. And then this begs the really big thing that Peter was saying in his previous slide, which is there are many radiation oncologists. In fact, Drew Ridge was a big proponent of this, to say unknown primary patients should just be treated with radiation. If you're not going to change what you do, then why do all the surgery? And our medical and radiation oncologists would, I think, have a hard time calling a TORS and neck dissection with a positive margin a big biopsy and not adding chemo, or saying that this is not a positive margin on a resection with an attempted definitive resection, right? I understand the spirit of what Jeremy's saying, but this is the heart of the discussion with the unknown primary. Why do an operation if it's not going to change what you're going to do at the end of the day with the radiation? Because that's where the major toxicity comes from. And we don't have an answer to this, but there hopefully will be some trials that can answer this question in the near future.
Peter, why don't you tell us what you guys did?
Yeah, we've got 6 minutes to finish this case. Let's go.
Oh, okay. Very good. Okay, so for this patient, we took him to the OR and we got a really good look with the pan endoscopy, and the left tonsil did actually feel firm, and the right tonsil was soft. So we biopsied it. Frozen section showed squame, so we were done. And the patient wanted to think about what he wanted to do with treatment. So I talked to him about this before, and we talked about RT versus surgery. And so I presented him with both of the options, and he said he wanted to proceed with surgery. And he had talked to some friend of his who had RT, and he said, I'm not getting RT no matter what, just surgery is all I want. And we thought that was pretty reasonable. And so we went ahead and we did the completion, or not completion, but we did the whole left radical tonsillectomy. And then in my practice, I always do the contralateral tonsil as well. And I'll mention why in a second. And then we did the ipsilateral neck dissection. So sorry for the glorious self-promotion here, but this was a paper that I did when I was a fellow, and in our series when I was a fellow at Ohio State years ago, we found 10% of our patients with known tonsil cancers had another cancer in their contralateral tonsil. So this has been part of my practice for years, and I've found personally in my practice it's been a little over 10% have had a contralateral tonsil cancer, usually very small, but it's still there. And so I bring this up because that's exactly what ended up happening with this patient. So here's our pathology on the left side, the known tonsil. So 2.5 centimeter tonsil cancer, P16 positive. I did an en bloc resection with this one, taking the constrictor, kind of the standard lateral oropharyngectomy approach, and ended up getting a 5 millimeter margin on it. No PNI or LVI. We had 2 positive nodes. One was 2.7 centimeters and the other one was 5 millimeters. I didn't put that on here, but it was very small, and no ENE. So T2, N1, M0, and a contralateral tonsil did have a small cancer and focally positive on the deep margin. And so we have a T1 on the other side. So now would be the question, okay, if we didn't have the right tonsil in the question on the left side, our discussion tumor board would be, he's got 2 nodes positive.
Yeah.
We should probably recommend radiation therapy.
So let's ask the expert. I mean,
yes,
I love it. Another very non-controversial, easy case. Okay, so Jeremy, he did this beautiful operation, and now we have this pesky 5 millimeter tumor on the other side.
We're
What
definitely
would you
not finishing in
recommend?
6 minutes, Babak.
Yeah.
We're definitely not finishing in 6 minutes.
Oh, we will finish. All right.
Well, so yeah, am I ignoring that right tonsil, Peter, or not?
Well, I was saying, like, normally,
Should we ignore it or not?
If we ignored it, then that would be our discussion on our tumor board. Should we radiate this side or not? And it would be like 50-50 in our tumor board, and kind of leave it up to the patient, discuss it with them. And I can tell you this patient was adamantly against radiation, so he wouldn't want that for this one. But take the whole picture into consideration. What would you do? What do you think?
Well, 2 nodes, he would definitely get radiation at our institution, at least to the bed, to the neck. The contralateral tonsil, we'd spend probably an entire tumor board arguing as to different options. I would argue to go back and resect the deep margin and then just radiate the ipsilateral neck.
Got it. Dr. Hessel, what would you do? What would you recommend?
Yeah, that's interesting. First of all, I apologize. I got a phone call in the middle of this. Yeah, I think our institution would also offer radiation to the neck and maybe even to the primary on that side, since you will have some overlap at the tonsil bed. But it would be interesting to take the patient back and doing the TORS surgery on the left side just to clear that margin and then call it a day.
Okay. Now, let me ask Dr. Gross a question. So not all of us do routine contralateral tonsillectomy. And if that 10% is true, well, if you look at all these patients who had TORS, the rate of failure is definitely less than 10%, especially in the contralateral. What do you think? Should we just ignore these microscopic tonsils? Is it like microscopic thyroid cancers that they might not never grow? Where are we with this thing?
I think it's a really curious finding. There's so in my practice, I tend to not take the contralateral tonsil routinely. Just again, it's all about function, and patients function better if they have a good side. And there's a lot of experience from the Princess Margaret and from MD Anderson about unilateral radiation for tonsil cancer. Over 1,000 patients between the institutions, and the failure rate in the contralateral tonsil is just not observed. So, it's hard to square that, I guess. I think that the risk is very, very low to the contralateral tonsil. I have seen it, but I've seen it like twice in my career. So I don't know what to make of it, but it's not a routine practice for me to do routine bilateral tonsillectomy.
It's not part of ours either, Neil. And actually, I think you took care of one of my patients that got a second opinion there for his second primary. And Caitlin, I want her to comment because she wrote a nice paper while she was our fellow looking at second primaries in long-term follow-up, because our radiation oncologist has done some prospective trials of sparing the contralateral neck and also just sparing the primary site as well on tonsil cancers. So Caitlin, you want to comment on those results?
Sure. We looked at a second primary. We looked at both base of tongue and tonsil cancers, HPV positive, and the rate was like 2 to 4%. That's with the practice of not routinely taking out the contralateral tonsil, and with a average follow-up time of like 10 years. So I think I guess my takeaway is that many of these really tiny second primaries may not necessarily be clinically relevant, even when we're looking at relatively long-term follow-up, 10 to 15 years.
Perfect.
Great
Okay.
discussion, guys.
Excellent. So, so what did you decide, Peter?
Well, I could not convince this patient to do any radiation, so we went with more surgery, and we decided to stage it, knowing that if we're going to do like maybe not as radical of a tonsillectomy on that side as we did on the original side, still, if we had done that very soon afterwards, I think he'd probably need a G tube for a long time, and he would be miserable. So we staged it. So we waited 3 months and did the contralateral completion tonsillectomy. I left a strip of constrictor muscle there, so we didn't go all the way through to the parapharyngeal space, and we did a right neck dissection, and basically everything was negative. So no tumor in the specimen, negative nodes, and so T1N0 on that side. And now he's about 18 months post-op, and he's back to working full-time, normal speech, normal diet, and he's done really well. It's worked out well for him so far. Hopefully it continues to.
And no radiation even for the side with positive neck.
Correct.
No,
he was just adamantly against it, and even though we told him like our recommendation is to go with radiation, and he had a friend who had it for oropharynx and did not want the same side effects, so he refused.
Yeah,
so you stole away from Bill Mendenhall.
What's that?
You stole him away from Bill Mendenhall.
Yeah, stole or saved, one of those two. Yep.
All right. Thank you. That was a fantastic case. In the interest of time, we got to move on to Dr. Sim's case. If you stop sharing, Peter. Excellent case.
Thank you.
And Dr. Sim from Indiana. You've been patiently waiting.
Guys, here's my answer.
This is a
You're
great
a little
session.
quiet too, if you could speak up.
Oh yeah, can you guys hear me?
Yeah.
All right, great. All righty, let's go right into it. 60-year-old white
Can you
male.
put on the presentation mode your slides?
Oh, I'm
please?
sorry, yep.
Thank you. Okay.
Uh-oh, there we go. 60-year-old patient presented with a left neck mass, some throat symptoms, given antibiotics by his primary care doctor for a month, no improvement. Has a smoking history. Surgical history-wise, had a tonsillectomy, palatine tonsillectomy as a child. And so in clinic on exam, mobile, left neck mass, and laryngoscopy shows a pretty well-defined tumor. Appeared superficial on, palpation and inspection, but seemed to cross midline. So here's a CT scan you can see with contrast. Here's the tumor on sagittal and axial.
Let me ask a quick question from Amy and others. Amy, for these base of tongue tumors, how often do you get MRI?
Hang on, sorry, how often do I get what?
MRI for these base of tongue tumors.
Yeah, so I have always, our standard workup is to start with a scan, CT like this, and then get a PET. So I don't know if we would have added an MRI on top of those two things to see. Also, because it's approaching midline, I'm not really thinking of this as a surgical tumor. So it doesn't help me in my planning, at least. And we haven't seen all of the facts yet, so maybe I'll change my mind on that. But I would be probably not getting an MRI. Maybe Neil would get one, but because of our way we do our staging, I usually don't get an MRI.
Uma, what about you guys in Pittsburgh? How often do you get MRI?
Rarely. The reality is I think somebody said this before, the modality that your radiologist is most comfortable reading and helping you to understand the surgical anatomy is what's most important. And so our radiologists are very, very comfortable looking at CTs. And so for us, unless there's something really particular that we want to know about, something of the tumor and a prevertebral invasion, for example, larynx, no, that's not the case here, we really don't get MRIs.
Okay. What about you, Ryan, at St. Louis?
We routinely do not get MRIs universally. They're more costly. They take more time. Our patients travel from hours away to come see us. So we almost always have a contrasted CT scan and either a chest CT or a PET.
All right, good. And for those of you who missed, Dr. Richmond also mentioned that he doesn't routinely get MRI. Okay, go ahead, Mike.
Can I just comment? I do like that he's showing, the sagittal section here. So you can see the relationship of the tumor to the hyoid bone. I think that's really, really important.
Yes, excellent point.
And this is an example, a really nice CT where you can actually see the tumor well.
Yeah.
Yeah, agreed. We don't, in Indiana, we don't get MRIs routinely either. Oftentimes I think with CT and PET and palpation exam, I find that, vast majority of the time you can all the information you need. So, and then here's the PET scan. So definitely seem to, cross midline. And so I think that's the point of this presentation. And that's a dilemma for some. It depends on, for some, this is a relative contraindication surgery. So
let's ask the expert. Go ahead.
I used to get PET scans routinely for these patients, but I don't anymore. I rely on the CT as a workhorse, and this is a good example of why. Because the PET scan overestimates the extent of disease. When the patient's presented a tumor board, even if it's a relatively small tumor, it can look giant based on that. Now, this patient, I'm not saying it would be an ideal surgical candidate, but just in general, the PET scan tends to overestimate the disease, particularly in the pharynx.
So, Dr. Richmond, this is the cousin of Dr. Ziglewski's patient and hates radiation. Comes to you with this scan and says, "Take this out." How would you approach these?
I'm going to have my radiation oncologist wine and dine them. But honestly, that's a good point. Is a lot of people come in with preconceived notions about what radiation is, and they've met someone on the outside that hasn't done a lot of head and neck, and they just need to meet an expert that does head and neck radiation and know what they're getting in for. So this is something that personally I would not treat with upfront surgery.
Okay, great. Let's do a couple of other quick comments. Uma?
Yeah, I just wanted to echo what Neil said. In the famous words of Dr. Jonas Johnson, we should stop petting our patients. There's I think a overuse of PET scans up front. Also, remember now with CMS rules, you only get a few PET scans, right? 3 PET scans over the life of the patient. So if you're going to get a PET, make sure it's a simulation-based PET so they can use it for CT SIMS. Otherwise, you can run into the risk of over calling it. The second thing that I really like about anatomical imaging cross-section, whether it's CT or MR, is that really give you good delineation of the vascular anatomy, the neurovascular pedicle, how close it is. If you could go back one slide back, Dr. Sim, I think you had a really nice view here in the sagittal the axials of where that neurovascular pedicle is and how close it is. So as you get to that margin of that tumor laterally, the GT sulcus, you're probably going to have to come across that lingual, and you may end up getting close to the hypoglossal also. And this is one scenario where you really need to tell the patient, if you have surgery, you may end up with a significant side effect from this. It's not a significant consequence from this of dysarthria and dysphagia. So that's one point is anatomical imaging, I think, is, in my opinion, really, really valuable and maybe more important than PET functional imaging. 2, I think this person would probably be better served with radiation. And 3, if there's some vociferous objection to that, the only way to potentially consider this person resectable would be to enroll them in maybe Dr. Upaluri's like neoadjuvant trials or something along those lines, where you could study this tumor, get some information from it, and maybe get some response that might affect the treatment of this patient, or maybe consider using surgery. But again, those are clinical trials that should be done under very, very tightly controlled and evaluated circumstances.
Okay, let's
Those are
see.
good points. To play devil's advocate for 2 seconds, we've really learned that the tumors that aren't extending into the extrinsic tongue muscles, and this one here on that axial, you can see there's a nice plane there between those muscles and the tumor, and the ones that are within the hyoid bone and not going past it tend to spare the vessels pretty well. And our institution on the PET scan, our base of tongue patients, we tend to PET a lot because we care about the contralateral neck, because it helps us decide if we're going to do surgery or not. Here's the reason why. Our radiation oncologists want to only radiate ipsilateral necks if they can, and not bilateral necks. So if a patient has a contralateral node, we know that patient needs bilateral radiation and we'll treat them non-surgically. If the patient only has ipsilateral disease and their tumor is resectable with low morbidity, we'll tend to favor surgery and do bilateral neck dissections. And if it's pathologically N0, we have trials out that shows that their risk of failure in that neck is exceedingly low.
Great. Okay. We got 8 minutes. Mike, tell us.
Yep. So I think we've kind of jumped the gun. We've done a lot of discussion, but biopsy confirms HPV positive, T2N1. So we've kind of been discussing it already, but treatment options. So obviously, if we do surgery, most of us here are going to do a robotic resection instead of open. I think this is a good point of discussion. Do we do the neck ipsilateral versus bilateral at the time? And if you are doing bilateral, like Dr. Jackson is talking about, do you do the TORS and the bilateral necks concurrently, or do you stage neck due to concerns of swelling and obstruction
Great.
and such? So that's I think good discussion point.
Yeah, great question. Let's ask Dr. Richmond. What can you comment? Unilateral, bilateral, the stage at the same time.
So for us, if we're going to do a base of tongue TORS, then anything that approaches within the central third of the tongue, we need to address the contralateral neck. And so I usually stage it. So I'll do the TORS and ipsilateral neck, and then I wait for pathology. If everything's looking favorable, meaning that we could potentially get by with nothing or with radiation, then we'll stage the contralateral neck. If the ipsilateral neck comes back ugly with ECE or some other adverse findings, and we know they're bound to radiation with chemo, then obviously we're not going to do the contralateral neck. They're going to just move on to adjuvant therapy.
Fantastic. Dr. Hessel, what's the philosophy at MD Anderson?
Right. So I wouldn't do surgery for this. I would offer radiation, but let's make it salivary gland cancer. So that way we have to do surgery. I would stage the neck as well. Do the neck on the dominant side where the majority of the vessels are going to be. So in this case, I think it was on the left side. And then stage the right side. Once they're healed up and feeling a little better, you've got patent jug and all that other stuff, then go to the other side.
Dr. Duvori, what's the stance at Pittsburgh?
So yes, I agree, Dr. Hessler. We typically do not treat these tumors that approach midline or cross midline with surgery. We typically treat these non-surgically. And I know that the WashU group has a lot of experience, having been strong proponents of surgery throughout the eras and the decades that we have had this sort of pendulum. But we've actually not been able to adopt that and convince our radiation oncologists of this. And I think this is really a really important point that I think, Babak, we should talk about, is that this has to be a multidisciplinary conversation with your team, right?
Yeah.
We can't operate on all these patients, and there's nobody that I cannot operate on. Well, very few, right? You can do anything. The question is, should you do it? And does it actually help the person? And at the end of the day, if your radiation oncologist is going to do the same type of treatment, whether you did the surgery or not, then I would argue that you are increasing the morbidity for the patient. The WashU group has a very progressive, I would say, radiation oncology component with Wade and and his view and perspective on things. And I applaud them for that, but that's not universally shared by everybody. Let's just put it that way, right? So for the younger people in the audience, you have to understand that when we talk about this from our experiences, it's because it's that team-based approach, and you have to understand what that MDC collaborative approach is going to be to the patient. Don't do the surgery because you can. Do it because you've made the uniformed and multilateral decision to do it the right way and get the patient the best possible outcome. So, pardon me, Ryan, I'm not criticizing the WashU approach by any means. I'm just trying to clarify that different institutions have to play by different sets of rules in this kind of scenario. Awesome. Having said that, if this were a case that needed surgery, I would stage the necks because I do think that swelling is a concern. And you also want to make sure that you know what you're kind of getting into. If there's a margin that's close and you want to go back in and re-resect it, it gives you that flexibility. Sorry for being
Jabari, question for you then. If do you have a limit to what that midline tumor is? Like it just, if it crosses midline, then you won't operate, or is it within a centimeter, or is it,
yeah,
do you
so
have a hard fast?
I think you heard Dr. Richmond's philosophy on this. And we've kind of adopted the ECOG 3311 because that sort of codified something in writing about what we would consider acceptable or unacceptable for contralateral neck metastasis. Now, recognize that that's based on retrospective data. That's not, level 1, phase 3, randomized, all that kind of stuff.
Yeah.
1 centimeter, end of the day, 1 centimeter is what we go by. And E3311 really changed a lot of what we do if you think about it, right? 3 millimeter margins, we now kind of accept that. There's no hard and fast gold standard for that except the WashU data, which showed that that's where some of the failures happen. So I think we basically go based on ECOG 3311.
Okay, quick question for Dr. Gross. So we heard from Harvard for UPMC. What's your cutoff for base of time? How close to the midline would you still do surgery?
Yeah, no, it's a really ripe area for discussion. I tend to be a midline person. So if it crosses the midline, then I don't take that patient for surgery. If it's short of the midline, then I think they're a candidate. And I will say that I'm also a unilateral neck kind of a person. So if I'm operating on a base of tongue tumor, I'll do the ipsilateral neck. If they need radiation based on the neck or the primary, then they'll end up getting radiation to both sides of the neck. If they don't need radiation, I'll observe the contralateral neck. And those patients do well. I have had, I think, a couple patients in my career who failed contralaterally later when they weren't radiated, but they've been very, very salvageable. So, that's just my approach. I don't tend to do a lot of bilateral necks.
Okay, very good. Okay, we got 1 minute.
All right.
Mike, tell us what you decide.
Surgery, negative margins, 2 nodes positive ipsilateral, and then the contralateral neck was negative. So this patient received ipsilateral radiation and was.
This was a stage or all at the same time?
Stage, yep. And
stage.
With the contralateral neck being pathologically negative, radiation oncology was comfortable with just ipsilateral radiation. So I think it benefited the patient.
Okay. And then in terms of radiation, do they cover the entire base of tongue?
Yes.
Yeah.
Typically,
okay.
but I think that depends on, again, your radiation oncologist. Some will, at IU, our radiation oncologists do not believe in decoupling the primary and the neck. Not quite as avant-garde. So, but with that, they will eventually.
Quick poll for the expert. Everybody agrees with radiation alone after this case, or there are still holdouts that say radiation and chemo? Dr. Richmond first, then Dr. Hessel.
Radiation.
Radiation. Alone.
Nice job.
Okay. And then Uma, radiation alone?
Yep.
Okay, great. Fantastic.
One point.
Yes.
One just for everybody to know, when we talk about staging, it's important, but make sure you guys document it appropriately and think about it appropriately, because the new ACS guidelines for quality metric is getting started with adjuvant radiation within 6 weeks.
Yeah.
So if you don't document properly, the staging may make it seem like you were out of your window, right? So just as a teaching point or just something to consider for the younger faculty.
Yeah, awesome. All right, unfortunately, we are running out of time. This was a fantastic discussion panel. All cases were great. Thank you everybody for joining us, and thanks for all the guests. I'm really sorry that I didn't have enough time to ask more questions, but this was excellent. Our next session is going to be in June. That's our last session for the year. I hope you can join us. Love to have you back again with really simple, easy cases. So my sincere thanks to all of you, to the expert panel, Dr. Jeremy Richmond from Boston, Dr. Amy Hessel from MD Anderson, Dr. Uma Duvori from Pittsburgh, Dr. Neil Gross from MD Anderson, and our presenters, Dr. Caitlin Steppen from Northwestern University, Dr. Peter Ziglewski from University of Florida, and Dr. Sim from Indiana. And my friends, Dr. Jeff Liu and Mike Moore, who joined us.
Great.
Hope to see you soon. Have a good
Thanks,
night.
everyone. Have a good night.
Thanks, everybody.
Thank you.